We're at the Deuk Spine Institute getting ready to do a live broadcast of a patient's spine surgery who has really 4 bad discs in his back, but the bottom 2 are causing all the problems, at least the majority of them. We're going to fix those 2 discs. We got to go on both sides. Dr. Deuk here, we're going to get started, okay? I'm going to give you a little numbing medicine. You might feel a little stick and burn. Sorry about that. I wish there was an easier way to do the injection. If there is, I don't know about it. Would like to know. All right, first step here is to get into the L4-5, L5-S1 discs. He's got herniated discs on both sides at L4-5 and L5-S1. Now, along with the herniations, he's also got degenerative discs. And degenerative discs are basically discs that, you have a pickup? Degenerated discs are discs that are, actually I think we're okay, Luis. Shot? Collapsing. And collapsed discs happen as a result of herniation, shot, that goes untreated, shot, and over time that collapsed disc gets worse. Shot. I love it. Shot. So I'm using the x-ray to navigate the needle right to the bottom disc, L5-S1. Shot. I can tell you, based on his MRI, that he has a herniation here. Shot. And that herniation is literally crushing his nerves on both sides. Shot. Let's get an AP. I'm going to use a side-to-side view of the x-ray as well as a front-back view. The front-back is called AP, the side-to-side is lateral, to navigate the needle right to where I need to be. That looks really good. This is going to be the L5-S1 disc. You agree, Luis? Let's go back to a lateral view. All right, you can see the sacrum was below the needle and the L5 vertebral body is above. So we're right at the L5-S1 disc, and that's our first disc we're going to fix. Okay, we're going to make a little local and then skin incision. I'm going to give him a little more num-num. Num-num is numbing medicine. I won't need more after this. I promise you that, Luis.
Well, we need it for the DPR. Anyways.
I think we're okay. The DPR will be 1 incision. We're fine. I'm going to make my incision. It's going to be 7 millimeters, a 1/4 inch. And I'm going to go in with my second needle, and I'm going to go to the next disc, which is the L4-5. Now, the first part of the Deuk laser disc repair surgery is always to get inside the 2 discs we're trying to fix, or 3 discs, however many it is. In this case, it's 2 on each side. Shot. You can see the needle is near the facets. Shot. We're going past the facets now. Shot. I'm bumping up against the superior facet of L5. I need to be a little bit more lateral. Shot. Everything okay, guys?
Yes, sir.
I'm talking shot. All right, I'm going for the L4-5 shot. Bumping up against the superior facet again, but I'm a little more lateral so I can get around it. And there we are. Perfect trajectory. Perfect lateral view, AP view. So we're going to take a front-back view again just to make sure I'm in the right place. You have to use 2 views. If you don't use 2 views, you won't know where you are. There we go. It's perfect. We're right between the pedicles, right where the disc is. So it's going very well. And my anesthesiologist today is doing just an amazing job. Thank you. Dr. Edwards hails from Florida by way of Las Vegas, right?
It's a common theme.
Yeah. And heck, I tried recruiting you a few years ago, right? A year ago or so.
Oh, yeah.
Unsuccessfully.
I wish I could have done.
I know. But we are getting busier. Sean? So, you know, maybe when you're not in Vegas. Sean? Yeah, I think we are going to need 2 anesthesiologists eventually. Because I'm not going to settle for a nurse anesthetist. I'm just not a settling type. And I want to have the anesthesiologist for the patients. I know there's some very good nurse anesthetists out there, trust me. I get it. But, all right. Let's get an AP. Let's see where we are here. I may be a little bit too lateral. You can't tell if you're too lateral with your needle on a lateral view. You have to use an AP view. All right, so there we are. And we're a little bit lateral, but not horribly lateral. I think I need to go, let's see, give me a lateral view. I need to go a little bit more lateral. So I'm bumping up against the facet joint, which means I need to go a little bit more lateral. Shot? Otherwise, the trajectory looks pretty good. Give me a Raytech shot. Boy, a lot of arthritis here. Shot? How is he doing? Is he awake? All right. I think I need to come from a little more rostral and aim south. Shot? Shot? Hey, it's Dr. Deuk. You're just checking on you. Everything okay?
Yeah.
You're doing great, by the way, and I appreciate your laying still for me. It makes your surgery go that much better. Shot? All right. A lot of arthritis down here. Shot? A lot of arthritis. Shot? Yeah, it's actually pushing my needle north. So I'm going to have to try a little bit different angle. Shot? It's just getting stuck in the ball of arthritis there. And it's getting pushed north again. Shot? 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 AP? Feel like this arthritic facet joint's pushing me laterally. That's one of the arthritic joints we're going to be fixing later because it's so full of arthritis it's causing facet joint pain. Yep. All right, iliac crest, that's why. Let's go back to a lateral. Any questions from our audience?
No current questions.
All right, let's show the audience why we do the Deuk laser disc repair. How does it work? Shot?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. the annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. So you see why we do the Deuk laser disc repair for damaged discs. It's to clean out the tear that causes the back pain and remove the herniation pushing on the nerve root. Sean? All right, I'm still struggling to get into the L5-S1 on the right side. I've done it on the left. Give me an AP. I've tried repositioning the needle a few times. Patient's done a great job being very patient. You like that? Patient, patient. But you could see the tip of the needle there, Jordan. Show them all that arthritis. It's grown off to the side. All that's bone there. And that's what I'm trying to get around. May have to go a little more medial. See if that helps. Shot. The other needles look great. Just this one here it's just not giving me any. Shot. Any help? Yeah, he's got a high iliac crest. That's part of the problem right here. Shot. It's deflecting me more north. It could come in a little more north. Let's give a little more num-num. And because of the iliac crest, I'm having to start further north and try to aim further south as I go down to the L5-S1. Shot. 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 There's too much arthritis here. Shot. I just cannot get around it. It's very interesting. Shot. There's just no way. Literally encased in bone down here. AP. Just a quick AP. All right, you can try to be a little more lateral. Thanks for keeping them comfortable. This is the worst part of the surgery, I think, is getting into the disc that we need to get into. Shot? Yeah, shot. I know that's your arthritic area. You're doing great. I apologize. Shot? All right, we might have it this time. Shot? Let me know if you feel any pain, okay? You feeling it? Where? Yeah, but where do you feel it? In your back or down your leg?
Not much down the leg, every once in a while with it.
Shot. Shot. All right, let's get an AP. We're almost done. We're going to be able to put you to sleep soon, okay? I've had to try a few different approaches on that right side at L5-S1. All right, so still a bit more lateral than I want to be. I might be close enough. Part of the problem is the rotation of the spine too. You all right? Where do you feel that? Down your leg? How far down? Does it go past your knee or not?
Yeah,
Past your knee.
yeah.
All right. Let's get an AP shot again. Give me some rotation. I think we're off on orbit by 2 degrees. Again. She just shot. I'm not sure that corrected it. Let's try something else. Shot. That's better. Alright. Just don't know if I can get under this nerve. I'm going to go back a little bit more. Let me see what I can do, okay? Shot. Yeah. Shot. Shot. No leg pain, right?
I have numbness, that's all.
Yeah. But anything new? Down the leg or not?
No, it's just numb.
There, do you feel anything or are you still good?
That's all.
No pain down the leg? Huh?
A little bit.
Shot. All right, let's get an AP. Nothing right now?
Other than numbness.
But the numbness you've had before, right? No, I'm talking about anything new. You had numbness before, but anything new.
The numbness is a little bit more intense, that's all.
Huh?
The numbness is a little bit more intense.
A little more intense. Probably from laying here. Where do you feel it? In your back?
In the back, yes.
Yeah. That's where I would expect you to feel it. Yeah, that should be in. Yeah. All right. Well, let's see if that is. Well, you see why I need the patient awake for the surgery in the beginning, because they're helping me make sure that we're not too close to the nerve root. You did real good.
The pain's in the back.
I understand. And yeah, that's expected right now. You should get better in a few minutes. We're going to put you to sleep. And we had to start higher. Shot. Shot. Very close. Where do you feel that, Shot?
In the back.
All right, I apologize. That's your second bad disc on the right side. Shot. But we're almost done. Nothing down your leg, correct?
No, just numbness.
Yeah, the numbness you already had. Shot. Mm-hmm. All right. Try to relax for just a second. There we go. Good. All right. Are you better now?
Yeah.
As good as you could be for laying on an operating table, right? All right, let me talk to our audience. He has 4 bad discs in his back, but 2 of them we're not treating today, and most of his symptoms are coming from the bottom 2. He's also got pinched nerves from stenosis. We're going to try to unpinch those nerves. So he's got a tear on the left and right side at L4-5 and L5-S1. How much back pain do you have normally?
Worse now than it was.
A lot?
Yeah.
Bothers you? All right. So that would be 5-1. Let's try the other one. Make sure we're in. Shot. Shot. All right. All right. That is not. We're just not in the disc. Did you feel anything there?
Yes.
Maybe it is and it just came out. Is that where you typically get pain?
Yeah.
We done 18.
Shot? Is that where you typically get pain? How bad did that go at the highest? A 9? 7 or 8. So the highest one was an 8? All right. That should be enough. Okay, is it better now? So 5-1 is an 8 out of 10? Concordant? Okay. How high did that go? I can't, what, give me a number. 9 out of 10? Is that typically where you get back pain? All right, we're going to have you go to sleep, okay? When you wake up, we'll be done. Just count from 1 to 100 for me. Nice and loud. Yep. Keep counting. You're doing great. All right, so we tested both L4-5 and L5-S1. They are definitely causing his typical back pain. The only needle I'm concerned about is the L5-S1 on the right side. That's the one we struggled with the most to get it in. Shot. So I'm just going to be really careful on the right side at 5-1. I'm probably not going to just go down the needle or the guide wire. I'm probably going to get to the back of the disc and use the dilator to enter. That way I avoid getting into the bone. It's really hard to tell when the disc is collapsed if you're in the disc or inside the bone. You're doing great. Just relax. So I think the right 5-1 needle may be sitting inside his end plate or his sacral bone. You can see how when I did the 5-1 injection on the left, it actually filled out the disc nicely. Shot. Is he okay? All right, just take it easy. Everything's going good. All right, I'm going to wait a minute so you can get him a little deeper. Now, he's got really bad pinched nerves on both sides at 4-5 and 5-1, but he's having more numbness down his leg on the right side. So that means to me that his right nerve is getting pinched the worst. Let me know when you're ready, Doc. All right, just relax. That's your painful disc. Are you giving him a little more propofol? Let's go ahead and show our audience, why did the herniated disc cause back pain? What's the mechanism?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, Submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. We're getting ready to perform our first Deuk laser disc repair on this patient at L5-S1. You can see the blue stuff is the herniated disc, degenerated disc.
Thank you.
I'm using a grabber called the pituitary to remove those pieces that are already loose. Once they're removed, I can start with the laser. There's no point in lasering loose pieces because you're just going to remove them anyway. We're not trying to laser them, we're trying to remove them. So whenever you have a loose piece that you can remove with the grabbers, the pituitary, you just use it. Hello? Can you pay attention, Oscar? When you see the laser go in, you need to turn the laser back on, okay? All right, our patient is snoring happily in La La Land. We are cleaning out the tear with the laser at this point. Any questions from the audience?
No current questions.
All right, we've been broadcasting these surgeries now from Deuk Spine for about almost 10 years. And it's great to have an audience who's interested. There's the tear right there. You guys see the tear?
We see it, yes.
Good. The only way to really see this tear in surgery is with the endoscope. Microscope can't see the tear. It's too small, too deep. The microscope can't reach that far with its light and optics. And it's really a microscopic type of thing, but it's so microscopic that the microscope, the operating microscope, cannot see it because the operating microscope, the head of the operating microscope is far away from the patient's disc, so it can't get close enough to see it. But the endoscope sees it perfectly well. That's why these endoscopic procedures are special. They allow good illumination or lighting and good magnification, where they magnify the pathology so it's visible to the human eye, the surgeon's eye, to do surgery. Piece of herniation right there. There it goes, floating out. You can see the pink tissue right here. That's all inflammatory tissue. That's what we need to get rid of. We're going to go down there and get rid of it in just a minute. All right, any questions from the audience?
No current questions.
We've broadcasted so many of these surgeries now that I think people are starting to really understand there's a lot of consistency. When you figure out the right way to do something, you keep doing it the same way. Why do you think Colonel Sanders wrote down his recipe and sealed it in a vault? He figured out the right way to fry up chicken. And we're not sealing ours in a vault, we're sharing it with everyone. Then again, we're not frying chicken. Right, Luis? We're frying disc. Well, we don't have any oil. I don't know. Do you have to have oil? Is that a prerequisite to fry things?
Probably, right?
I don't know. Never thought about that. This is not the right setting for the laser. You've changed the setting. Jordan, will you check on him, please? This seems to be the right setting. It wasn't, though. How did you change the setting?
I did.
Huh? You didn't? Huh? Right now it's working, but it was a lot slower just a few seconds ago. Did you hear the difference?
Yeah, it was slower.
Let's make sure we don't adjust the firing rate. So I've talked about this before with the laser. The laser has two functions. One of them is to vaporize or break up covalent bonds, to free up pieces of tissue, break it down into smaller parts that are, easy to float out, like those parts right there you just saw go by. The other purpose of the laser is to create a pulse wave and use basically a pressure wave in this fluid down here. And it's a process called cavitation, where the laser energy gets into the water, the irrigation fluid, and creates a big pressure wave. You know, when a jet goes overhead and it creates a sonic boom, you hear a big boom. Same thing with the rocket launches. When they hit Mach 1, they actually create a sound wave. Well, this laser every burst creates a sound wave inside the liquid, and it causes a blast, like literally a physical shear or agitation, and it moves tissues out. It physically breaks up the herniation. So it not only delivers the laser energy to break up the herniation, but it also delivers a burst of energy, a sound wave, to break up the herniation. So Edwards, where are you living these days anyway? Port Orange? Huh? I'm not sure where that is. It's south of here? Oh, north of here. That's not bad. Did you ever work at Halifax?
Oh yeah.
You did?
Yeah.
With some of the neurosurgeons there?
Yeah.
Who, Venus?
Yep.
Is he still around?
Yeah. He goes between Evan and Halifax. He's a nice guy. He's doing a lot of heads, basically.
Heads?
And some spines. There's a guy named Torres, I think.
Who does spines?
Yeah, he had a couple disasters.
Really?
There's so much blood.
Yeah. That's why I tell people about this procedure, because we don't lose any blood, really.
That's why I had Yonic right at first.
Yeah.
Seems like he might be coming around now.
Well, he is
7 months.
so deconditioned, I told him he's got to do therapy. He didn't want to do therapy.
Yeah, he's got something in his head. He has a hard time doing therapy.
Yeah, he had some hamstring tightness, and he had some piriformis, and maybe even some facet pain, but the disc stuff was gone, which is good.
Well, you couldn't get in one of them though because of this huge
think so, yeah. I can't remember, yeah. But I don't think that's causing his pain. Usually, no. If I can't get into one, usually it's because it's so collapsed and stuck together that it's not moving enough to cause pain. Yeah, some people just take longer to heal. That's what I've seen.
No, but he's got something in his head for like, usually correctly anyway.
Well, he was supposed to go to France and do some rehab there.
He did. A little bit.
I get a lot of people like that that don't understand the value of the rehab.
Right.
And I can only do so much to explain it to them. This surgery fixes disc pain. It doesn't fix muscle soreness and muscle spasms from other muscles not directly related to the lower back, you know, like hamstrings and stuff. That requires PT. The problem is if you let a pinched nerve go too long, it creates a hamstring contracture. If it's,
Well, that's his. I think I'm pretty sure he has that going on.
yeah, I know. I know. I told him that. He just doesn't want to listen. See, the problem is if you have a pinched nerve, when you go walking, you don't straighten your leg out. Because straightening your leg out pinches the nerve. And so people start walking like you ever see those German shepherds with kind of the legs that never straighten out, they just kind of bent?
Right.
And you do that long enough, then you develop muscle contracture in your hamstring. And that's something that there's nothing in the world you can do but therapy to get rid of it. All right, just about done here. You can see the epidural fat at 12 o'clock. We're at the end of the tear. I've debrided most of it. Just a little bit left there. But things are looking good. Any questions from our audience?
No current questions.
Great. Well, we do like questions, so if anybody thinks of anything they want to ask me, feel free. Once again, this is the L5-S1, right, Luis?
Yes, sir.
On the patient's left side. It was easier to get into this left side at 5-1 than it was the right side. The right side we had some trouble getting in just because of the bone spurs and arthritis. So hopefully we'll be able to get in a few minutes. We'll find out on the right side. Usually when the patient's asleep, it's a little bit easier to actually get the dilator down there. So, but I'm pretty happy with the way things are going here. Are you happy, Luis?
I'm happy.
Luis is happy. All right, let's see. The nerve root's going to be right up there in that fat. You can kind of see the dura just below it, the white stuff. That's the nerve root. We're just below the nerve root. That's the exiting root, by the way. You can see how close the herniation is. It's just underneath the nerve root. And he had a lot of herniation here. A lot of scarring from herniation. I've been able to debulk it. Done here.
Lights on, please.
Antiseptic. We're going to clean this out. Looks nice. I'm very happy with that. Scope off, please. Yep.
We have a question.
Sure.
And this comes from Hulk Hogan on YouTube.
Is that the real Hulk Hogan?
I hope so. But no, Hulk asks, "Hello, doctor. I am very interested in your procedure of repair. I have a work injury that has affected 3 cervical vertebrae that I would like to have done by you. It's been causing arm and hand issues."
Yeah. Well, Hulkster, if you don't mind me saying, absolutely. We do this same procedure on the neck. We've broadcast it over the internet so you can actually watch it, but we would be very happy and honored to do that for you, whether or not you're the real Hulk.
He said, "No, I'm not."
It's cool. I like the Hulk. Man, Hulkster became popular when I was a kid. And I know he's had some bad luck with Laser Spine Institute. I think it was Laser Spine Institute that messed him up. The good news is we don't do the same surgery as Laser Spine Institute. We do a much better version. We don't have those kind of problems. And yeah, we'd be happy to do it. We do take work comp. I don't know what state your injury is in, but if you want to contact our work comp coordinator, I'll give you her phone number. Her name's Elizabeth. And we got to try to get your insurance carrier to approve for you to come here and get treated. So Elizabeth's phone number is 321-775-8010. 8010. She's our work comp coordinator. Give her a call. 321-775-8010. If you've got a workman's comp injury, you want to be seen at Deuk Spine for herniated disc or spinal stenosis, we'd be happy to treat you as long as we can get the authorization, obviously. If not, then you'll be basically having to pay out of pocket. But we do take work comp. We've had a lot of work comp insurance companies pay for the laser surgery, so hopefully we can get yours to cover it as well.
The Hulkster said he's from Pennsylvania.
All right. Well, we do take Pennsylvania work comp as long as they'll approve it. All right, lay still. Everything's good. Shot. Now, for the cervical lasers, our patients are completely asleep with a tube down, completely out of it, under general anesthesia. Let me know, doctor, when I can proceed. So it's a little different than the lumbar. The lumbar, we have to kind of work around the nerve root, so we need the patient awake to tell us during certain parts of the surgery to tell us if we're too close to the nerve root. If I'm too close, I'll move further away. But I wouldn't know that without their input. That's because everybody has a little different configuration of their nerves. All right, so we're working on L4-5 next. I can feel the herniation, so can he. And now he's asleep, so we're gonna literally go through the herniation into the disc, right through the tear. Shot. I'm gonna pull my guide wire back just a little bit. Shot. Nice. Shot. Shot. Man, that's a big tear. You could feel it. It is big. Yeah. See how easy it went in? That's an indication of how big that tear is. Big tears usually mean more pain. And bigger herniations. Remember, the herniation is that jelly in the middle. It's got to come out through a tear. So the bigger the tear, the more likely the herniation happens. I think we're good. Yep. Yep, we're plenty good. All right. Any other questions?
No current questions.
Yeah, I read about how the Hulkster got screwed over by Laser Spine Institute. I wish he had come here to get his back surgery done. We wouldn't have screwed him over. The only thing I wonder about the Hulk is would he have fit on our operating table, right? I don't know how tall he is.
Oh.
Gotta, huh?
The Hulkster just commented, it's not been approved yet. I've been off work for 1.5 years, and now, but I have Medicaid insurance.
Medicaid, yeah, we won't take Medicaid for this. Medicaid won't pay for this. That's the problem, Hulkster. Medicare and Medicaid don't pay for the DLDR yet. Someday, yes, maybe, but right now we haven't gotten them to. So we need to work with your work comp insurance, try to get them to authorize for you to come here and get it done. That said, whatever we can do to help you get that done, we're happy to do. We'll talk to your lawyer if you have one. I think it helps, to be honest with you, if you do what's called a free telemedicine visit, where I meet you over the Zoom call for 10 minutes. And I'll put it in your hand, Luis. You just give me that grabber. We'll do a 10-minute Zoom call. And during that time, I could then write up an opinion based on our interview and the history that I take and the physical exam that I do. All right, let's go find that tear. There it is. See the tear right there? That is the very deepest part of the tear. You see the annular fibers on the right coming off the bottom of the disc, the surface? That's where the herniation comes out. That's the insidemost part of the tear. That's why we went deep in the disc to find it and debride it. This is the part of the disc that doesn't have much blood supply. But look at all the scar tissue. The only way you get scar tissue is from inflammation. So that tells you that even the inside of the tear gets inflammation, which means the inside of the tear gets blood supply. How is that possible? The answer is it grows there. It grows from the outside of the disc to the inside. Okay? And that process is called neovascularization, which happens with chronic inflammation. You get a growth in of nerves and blood vessels that weren't there before. Woo, look at all that pink stuff on the left. You know, we may need a bigger laser fiber.
This one,
Huh?
then we need a bigger scope there.
No. I think we could fit a.
I think this is the biggest one.
This is the biggest they
Yeah,
make.
I think that's it.
It may be.
The other one that is bigger is the side fire.
No. That thing, no. So you can see the laser is just really good at removing all this scar tissue and herniated disc and granulation tissue, cleaning up the tear. We call this an annular debridement because we're debriding the annular tear. You could call it an annular tear debridement, that's really what it is, but just to keep it simple, an annular debridement, which is really a debridement of the annular tear. Look at all that scar tissue right there. That's just from years and years of inflammation. Yep. Look at that granulation tissue, the pink stuff. That's where all the pain comes from, right there, as a bundle of nerves in there. And that's so sensitive. That's what the patient didn't like earlier when I was putting in the dilator through there. It was going right through that tear in that sore spot, and it was causing the patients to feel that pain. So that's why we had to put them a little deeper while we were doing that, but that's where all that pain comes from. It's very sensitive. It's almost like a pimple, you know, but a pimple is full of bacteria. This is not full of bacteria. There's no bacteria here. There's herniation right there. This is well, I wouldn't call it an abscess, but it's a sterile process, meaning there's no infection. But there's still a lot of inflammation. All right. Any questions?
No current questions.
Now, something that a lot of doctors would not do, or maybe forget to do, is to go lateral. That's what I'm doing now. So remember, when you enter the tear, there's going to be a medial part that goes towards the middle, and there's going to be a lateral part that goes towards the outside. And if you're not careful, you don't get the lateral part, you're going to end up leaving some herniation there. That was the lateral part that I just got. This is the medial part. So you got to look to the back to look for the lateral part.
We don't have a question, but we do have a comment from the Hulkster once more.
Yes, Hulkster.
And he replied, I will call him this week to find out. I have a top neurosurgeon in my area and he wanted to put 2 replacement discs and possible another procedure for third down the road, not wanting any hardware in my body.
Yeah, man, why would you ever want to go through 3 procedures either, you know? That's really crazy, to be honest. Not you, but for the surgeons. They all do that. They treat patients like an annuity. They're like, come in, we'll do one now, we'll do another one next year, and we'll do another one down the road. It's like, why would anyone want 3 surgeries, or 4 surgeries, or 5 surgeries? Doctors act like that's okay, you know? It's like, okay, people want to have the surgery one and done. That's what we do at Deuk Spine, one and done. Get it done. Our reoperation rate is 1%. That means we reoperate on 1% of our patients. That means that we have to go back and do it again 1% of the time. These other doctors go back and operate a second time like nearly 100% of the time. So just a completely different philosophy. Right. They're the top reoperating surgeon. You know, it's funny because I went to Johns Hopkins to interview, and they offered me the job of resident neurosurgery. And I said, what do you guys do in spine? He says, oh, almost all of our cases are reoperations. And I said, why are you guys doing so much reoperation? Oh, because people need more than one surgery. I'm like, yeah, not if you do it right the first time. So I chose not to go to Johns Hopkins because I didn't believe in their philosophy. I didn't agree with them. I turned them down. Love that place though, my God. Whew. You talk about posh. Man, they treat their residents so well. For sure, if I chose my residency based on, you know, how well we were going to be treated, like with lavish meals and experiences, I would have gone to Johns Hopkins. That place treats their residents really, really well. But instead, I went to the cold chicken sandwich residency in Florida. But I believe in the training was going to be a lot better, and it was. I was trained very well. Couldn't have been trained better. So. Nothing against Hopkins. I like Hopkins, but they just have a different philosophy. All right, we're done here with this one. There's the nerve. You see that white thing right there? That's the nerve root. We're just below it, okay? We're not through it. We're below it. Actually, let me get just a little more here, Luis. I'm sorry. Give me that laser back. I want to see if there's more right there. Sorry. I think we got it. Definitely no more blue stuff. Just a little bit of scar tissue. All right, any questions? Type them up. We've got the other side to do next. All right, that's good. Big irrigation. big irrigation. That's enough. No more. No más. No más. Uh-huh. Done. So we're going to switch sides. I'm going to go to the other side next. So we finished the left L4-5 and L5-S1 herniated discs. We debrided the annular tears. I'm going to switch over to his right side. This is the side where the nerve is really in bad shape. It's getting crushed. He's got numbness of his whole leg, some weakness. We're going to see if we can find that pinched nerve and get it fixed. I'm going to do that one last. Right, Luis? We're going to start with the L4-5 shot. So the nerve is getting pinched at L4-5 and L5-S1 on both sides. Bear with us. Shot. Mallet. Shot. Shot. This is a pretty collapsed disc, but we're going to get in there. Hold on. Let's go ahead and show our audience once again what is the Deuk laser disc repair, how it works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. All right, we have managed to put our tube in onto the right side. The type of surgery we're doing is called transforaminal because we're going through the foramen or across the foramen. That's the neuroforamen where the nerve comes out. Just below the nerve, we're going in. Endoscopic because we're using the endoscope. And spine surgery. Now there's a little bit more blood here. The reason is we just finished the other side. Okay? Remember we did the L4-5 on the other side just a minute ago. So that blood is coming from the other side. Thanks. Laser on. But it's the same problem on this side that we're getting. We're getting a herniation that needs to be addressed. And we're going to use the laser to remove it. Yes.
Yes, we have another question.
Sure.
This comes from Shaliz on YouTube.
Hello, Shalice.
They asked, if you have bulging disc with foraminal stenosis with inflammation and scar tissue, is the only option surgery, or is it possible for your body to heal on its own given the right conditions?
Hi, Shalice. Yes, I think it is possible for your body to heal the annular tear, but not completely. you're never going to heal it back to normal. Are we okay, Doc? The best you're going to do is heal it to the point where it stops hurting for a little while, and the pain will come back. It's just a matter of time. The only way to heal this disc properly is for me to go in with the laser and remove the herniation. It's the herniated nucleus pulposus that's keeping the disc from healing. And your body cannot get rid of that on its own. It's not possible. That's based on treating thousands and thousands and thousands of patients with this condition. I can tell you that right now. It's just not possible to do it. So you can partially heal it to where you feel better, but you're never going to get that thing completely healed. So you may get some improvement of your symptoms. Your back pain may get better. It may even go away for a while, but it will come back. It's just a matter of time. And the truth is, the sooner you get this done and fixed properly, the more likely you're going to keep your disc in a more natural state. Have you heard of degenerative disc disease? Degenerative disc disease is when the disc collapses over time. It's collapsing because of inflammation. If we can stop that inflammation from going any further, it's like putting a fire out. Okay? You all know what the wildfires in California, you've all heard of them, right? Those fires don't usually put themselves out. You know, you have to get the fire department to do that. You need people, you need airplanes, you need all kinds of strategies to do it. Well, it's the same thing with the disc. What's causing all that pain in the disc is inflammation. You see this stuff right here? Inflammation. And your body cannot get rid of this by itself.
We have a couple more questions.
Yeah.
This next one comes from Shalise once more, and they asked, is herniation and bulge the same thing?
Yes, herniation and bulge are the same thing. A bulge is just a small herniation. The basic components of a herniation or bulge is an annular tear, a tear through the wall of the disc, followed by an extrusion of this blue stuff, the nucleus pulposus, into the tear as it tries to escape the disc and get out. It's the actual nuclear material, the blue stuff, that is the herniation. And the bulge is what you see on an MRI. It's a small herniation, but it's a herniation nonetheless. Just semantics.
Our next question comes from Dark Sevi 476 on YouTube.
Sure.
And they asked, then this is an important question, how long would I need to heal before I would be able to go on rides like roller coasters?
How long would you be able to heal before you go on rides?
Yeah.
All right, great question. I would say 1 year after the surgery. You need to give it 1 year. That's the safe answer. And what I mean by that is being a safe answer is it means that sorry, I'm just working on this area here. What it means is that you could probably go back sooner depending on what surgery you're having done, like how many levels are being done, how bad your herniations are. I'd have to look. But the safe answer is 1 year. You might be able to go back in 9 months. If you have one disc and it's pretty well intact, you're heal fast. But I would say to be safe, wait a year. After 1 year, you can do what you want. Let's see the grabber. So 1 year after this kind of surgery. Now if you have a fusion, Instead, I would wait a year as well. I wouldn't go back before a year. All right, we're almost done with this disc. Everything okay, guys?
Yes, yeah, I just want to make sure this is sucking.
It's not an easy one. Just about done here. 30 seconds. And we're going to go for the 5-1 next. And then we're done here right now. See where the nerve is. The nerve is going to be up there in that stuff, buried in the fat. We've talked about this before. Why do they surrounded by fat? Who designed them that way? Of course, God did. What's the purpose? Well, the purpose is twofold. Number one, energy. Guess what? Nerves use a lot of energy. The nervous tissue of your body uses more energy than any other tissue. The second most energy using tissue is the heart, and then the kidneys. But nerves in the brain, nervous system uses the most energy, the fastest. So it's got to have energy right there. Now fat is an energy source, but not for the brain. It's an energy source for the peripheral nervous system. The brain only uses glucose, but peripheral nerves are not part of the central nervous system. They're not part of the brain. So they're allowed to use fat instead of glucose. Glucose is sugar, in case you don't know. But peripheral nerves are able to use fat. So having fat right there by the dorsal root ganglion, which is the most metabolically active part, because that's where all the cells are for sensation. And to be honest, your nerves are always sensing things. They're not always doing things like motor, but they're always sensorizing. So you have two sides to your peripheral nervous system. There's really three. There's an autonomic, which I won't talk about, but there's a motor side and a sensory side. Sensory side brings feelings from the skin, the joints, muscles, everything up to your brain. And the motor side is your brain telling your muscles to do things like walking or jogging. So the sensory system's always on, the motor system is not. And that's why the sensory system requires more energy, because it's using more energy. And the fat happens to be right where the dorsal root ganglion is, where all the cell bodies are for the sensory nerves. That's what uses energy, is the cell bodies. All right. The other thing the fat does is it provides padding, cushion for those nerves. All right, what do we got here? Lateral view. Now I think this, remember, this is the facet that was pushing our needle laterally. So I don't know if we're going to be able to get into this disc, but I sure am going to try. The reason the facet's pushing it laterally is it's huge. It's very enlarged. Look how dark the facet is. Look at the tip of the dilator right now. See that black area right in front of it? Jordan's going to circle it. That whole area there is all facet joint, and it's abnormal. It's dark because it's very, very dense bone. It shouldn't be that way. Facet joints should be light, a little bit of density. But his facet here at 5-1 on the right is so arthritic that it's actually very dark on the x-ray, much darker than it should be. We call that sclerosis. Shot? All right, we're getting close. He's sleeping like a baby. Now, I don't know if I'm going to be able to get in here. I'm trying. Shot? We're about to find out. I'm going to have to take this guide wire out in just a second, because the guide wire is going to guide me right into the sacrum. Let me just get a little closer, and then I'm going to take the guide wire out. But I think the guide wire is in the sacrum, because the needle, I think, went into the sacrum. All right.
Yeah.
Take this. I need to hold that thing. Hold on, let me look at it. Shot. All right, take it out. So I got to aim up a little bit and medial to try to get into the disc. Shot. It's forcing me down. The facet is. I'm going to try to redirect one more time. Shot. So I'm trying to tilt this tip up to go into the disc and not the sacrum. That might have gotten it. Shot? Yeah, I think we got it. Thank God. Whew! That was hard work. That's a level 10.5, folks. That is not for beginners. L5-S1 is the hardest disc to get to, and then you add on top of it big facet joints that are about 3 times bigger than they should be. Scoliosis, collapsing of the disc, all that jazz. And that makes it hard. Thank God we got in. I was worried we weren't going to be able to do that one. I think that's good. All right, we always save the best for last. And my team helped me. Great job, everybody. Jordan, great job on the x-ray. Luis, great job. Everybody, I mean, getting the patient asleep so I could get in there. Thank you, Dr. Edwards. Did anyone ever call you Dr. Edwards Scissorhands?
No.
Do you know who I'm referring to?
Yeah, the movie.
You know Edward Scissorhands, right?
Right.
Johnny Depp.
Johnny Depp played that.
That was a great movie.
The only thing I have in common with Johnny Depp is that we both speak French.
You both speak French.
French fiancés.
Nice. Well, you're better looking than Johnny Depp.
I don't know about that.
Oh, yeah. All right, here we are in the L5-S1 disc. You can see the end plate of S1 to the left at 9 o'clock. That's bone, basically. Remember, we were in this disc earlier, so there's some blood in here as we stirred up a little epidural bleeding. Not much, but a little bit. All right, there's our herniation. Let me see if I can get some more of it with the grabber. Any questions?
Yes, we have a couple of questions and comments.
All right.
First being is from Justice on YouTube.
Hi again, Justice.
And his comment is, I've been a welder in every procedure, every alloy not being able to leave a speck of pepper in any weld. I've been welding since I was 5 years old in Dad's fabric shop, and I'm 52.
Awesome.
52. I can do this procedure. Take out the blue, take out the red, and you're good to go.
Nice.
I can't wait till you do my surgery. I want to watch the whole thing while you're doing it.
Well, all right. So a couple of comments. First of all, I love the analogy. Welding is very challenging. A lot of people don't know that. Very cool. But you can't watch the surgery while I'm doing it because you'd be awake, and I don't want you awake. You'd be in too much pain. But you can watch it afterwards. How's that? I've never had a patient be awake and watch their surgery. Now, if you're really dead set on that, we could try it. You'd be a first. I'm willing to try new things if you really want to do that. I'm open to it, but you know, the moment you're in a lot of pain, we're going to put you to sleep. Yeah, I mean, you're right. I make it look easy, but you know, just like welding isn't easy, you guys make it look easy. This is not. Like the preparations, everything, same with the weld. You got to prep the surfaces, make sure they're ready to take the weld. And then, of course, the welding part is kind of easy, but it's all the preparation that goes into it, okay? Same thing here. The hardest part of this is truly placing the needle with that x-ray in the beginning. If I get that right, then the rest of the surgery goes really, really nice. Also the anesthesia, it's another one. Like, I'm very particular about my anesthesiologist because 9 out of 10 anesthesiologists won't do this procedure right. They're going to end up screwing it up. And the patient will be wiggling around too much. Makes it really hard for me to do my job. So having a really good anesthesiologist is very important. But if you got a good anesthesiologist and you got the needle technique in the beginning down right, then you're right, it's not that hard to do. It's just technical. I appreciate the comments. Look forward to it. I hope I can fix you someday. I really look forward to it.
These next two questions come from Shaliz on YouTube.
All right.
The first question being, would I ever be able to run marathons again, or is that risking reherniation?
Shalish, you definitely can run marathons again. Hey, look, I want to show you guys this. That's the nerve root right there, that white surface. You see that? Literally right there. Let me have the grabber so I could show them how close we are to the nerve. Now, we're not through the nerve, we're below it. So that's great when you can see the nerve. But that's why this was so hard to do at 5-1 on the right. See the nerve right there, the white thing at 12 o'clock? It's heading off to the right. That's where it goes down the leg. So we're just below it right here, doing the laser surgery below the nerve root. But we're not damaging the nerve root in any way. Okay. All right, here you go. So I'm perfectly fine working with the laser around the nerve root. It will not injure it.
The next question from Shaliz is, what is your percentage of reherniation after this procedure?
Yeah, great question, Shaliz. What's our percentage of reherniation with this procedure? The answer is 1%. 1 out of every 100 patients will reherniate. I will tell you this, every time I've heard of a reherniation, it's always because the patient did not follow my instructions. So, as long as you follow the instructions, I don't think you're going to reherniate. The instructions are quite simple. Doctor, we're almost done with this part of the surgery, about 2 minutes, and then we're going to go to the plasma rhizotomy. So as long as you follow my post-operative instructions with lifting restrictions and bending restrictions, then you will not reherniate. Okay? The reherniating people are the ones who literally are like, oh my God, the pain's gone, I'm healed. And then they go out and they play football a week after surgery, or rugby. Or they're out lifting cement bags, you know, and mixing cement. And there are people like that, I swear. They don't follow instructions. So as long as you follow the instructions, I could virtually guarantee you you're not going to reherniate. Okay? Just about done here. I'm so happy we were able to do this L5-S1 on the right side. You can see how bad it was.
We have another question.
Yeah.
This comes from Exist Outside the Box on
Yes.
YouTube.
I exist. Welcome back.
They asked, is there any kind of workout regime that can be done after the first 12 weeks?
Is there any kind of workout regime that can be done after the first 12 weeks? Absolutely. We recommend you start working out the next day. The kind of workout I want you doing is to be walking every day for 20 minutes, twice a day. All right, now as far as getting into the gym and hitting the weights, it's all about low weights, light weights, high reps. Light weights, high reps. You're just going to have to modify your workout behavior for a little while. Now, if you don't, you're going to be back for another surgery. And if you like having spine surgery done, then by all means don't listen to my recommendation. On the other hand, if you don't want to keep coming back for more surgery, then follow my instructions. Keep the lifting light. The nice thing about this procedure is that it literally is permanent. It lasts the rest of your life. It will fix you and your disc pain for the rest of your life, but you cannot get back too soon to working out. Otherwise, you will ruin what I just fixed. And then you'll be back for another surgery. Okay, we're done here.
Lights on, please.
Scope off. All right, we're going to leave you with one final thought. What happens if you decide to go with the fusion instead of the Deuk laser disc repair? Fusions do work if they're done properly. The fusion you'll see in this video is one that I did, and it is done properly. And if that's something you're interested in instead of laser, it's something we can do, but I don't recommend it. There's no benefit to fusion. It's worse in every way, but a lot of doctors still offer fusions, and I don't recommend it, but it certainly is an option. All right, we're going to leave you with this video, and we'll be back in another hour or less for our next laser. The next one is a girl from Tampa. She's a mother. She got 2 herniated discs and a pinched nerve on the left. So we're going to be doing a left L4-5, L5-S1 Deuk laser disc repair. See you then.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid.